Welcome, everyone. Welcome to season 6 of WSPOS webinars. We're very excited today to have a worldwide panel and audience and some fantastic speakers. We're honored to have two people who put a lot of effort and time into some cases for us and to share their expertise. I'm Kimberly Tan from Australia. I'm head of City Children's Hospital Ophthalmology Department, and I also work for Sight for All as a lead visionary. I'd like to introduce my two co-moderators who are well known to our audience and group. The first, actually, I'll just share the screen. I've now lost that. Sorry for a second. So I'd like to introduce the two co-moderators. The first is Max or Massimiliano Serafino, who's the Direttore of the UAC Oculistica, the head of Pediatric Ophthalmology Division, IRCCS Instituto of Gaslina in Genova. And the second moderator is Paolo Nucci, the Director of Biomedical Surgical and Dental Sciences, a full professor of ophthalmology at the University of Milan. I'd like to hand over to Max to continue the introduction and start the chat.
Yes, thank you, Kim. Thank you, and welcome everyone, and for this wonderful session, this wonderful webinar. And let me introduce the discussants of these two talks. So we have today with us Alcibiades Liasis from UK and Cyprus, and my friend Arif Khan from Emirates, and Christina Gert-Khaled from Switzerland, actually. And then we have Komur Sener, a dear friend from Turkey, and giants of Strabismus, Monte del Monte from United States, and Venkateshvara Rao from India. So thank you everyone to stay here with us today. And now let me introduce Professor Paolo Nucci and for the case presenter.
Hi Max, hi Kimberly, hi everyone. The case presenters today are two young ophthalmologists from Milan. She actually works with me, and I'm sure that she will appreciate her case. And the other case presenter is Susana Gamio from Buenos Aires, is another very young ophthalmologist. I'm sure that Susana will be happy with this. And we can start, I think. Sophia, you have 15-20 minutes, and then we have a long discussion with your case. It is a mystery case. And, we are eager to learn from you about this strange case. Please, Sophia, can you share your video?
Yeah, of course.
Maybe Sophia, sorry, before starting, could be make some announcement and type your question on the YouTube comment section for all questions you would like to do. And also, if you need any attendance or participation certificates for this webinar, please send an email to admin, ADMIN, at wspos.org. So thank you, Sophia. Please go ahead.
Thank you so much for the presentation, the kind words, and for the opportunity. So I want to share with you this case. This is a very interesting case about a young girl of 6 years old, born preterm at 29th week of the gestation, that required oxygen supplementation. Ocular history is with no relevant findings. Girl came to us for a regular eye examination. In family, father has myopia, and in the family, parents do not report any particular symptoms. So let's start with the eye examination. First of all, inspection, corneal light reflexes, cover test, and the ocular motility and stereopsis was normal. Visual acuity was 8 and 10 respectively for right eye and left eye. The anterior segment was unremarkable. and the IOP was 16. So let's start with the posterior pole, first of all, and with the multimodal imaging. I show you color fundus photograph of posterior pole, right and left eye. And what caught our attention, first of all, was the asymmetry in the peripapillary atrophy and the dragging of vessel in the right eye. So we want to explore more. First of all, we do an OCT of the right eye and left eye. On right eye, we think that there is an grade 1 foveal hypoplasia, and the left eye was unremarkable. Outer layer was unremarkable. So we want to explore more the periphery. This is the left eye with no relevant findings. And then I want to show you the right one. We find this fibrovascular lesion in the temporal periphery and an area of white without pressure in nasal periphery. I show you more. This area. So we want to examine the patient with an OCT over this lesion. I show you the video with the traction of the lesion. And then we perform a fluorescent angiography, ultra-wide field. This is the left eye. And then I show you the right eye, the early phase at 30 seconds, then intermediate phase at 3 minutes and 30 seconds, and then late phase at 6 minutes. And I want to show you this leakage of the lesion. And I want to underline that the temporal periphery is without vessel, without vessel supply, so it's ischemic. What we didn't know and what we find during the workup visit was that the little girl at birth had skin lesions, vesicular skin lesions that during life became verrucous, then hyperpigmented, and then hypopigmented. So what was missed is that mother is affected by incontinenza pigmenti. Incontinenza pigmenti is a very rare condition, X-linked dominant. The gene involved is IKBKG on chromosome X that is deleted. And this deletion results in a truncated NFKB protein that is unable to protect against cell death. So there is apoptosis, the apoptosis of cell in retina, but also in skin and neurologic tissue. So focusing on the retinal findings, we can find avascular periphery, neovascularization, hemorrhages, abnormalities in retinal pigment, epithelium, and PFV, foveal atrophy. And we can arrive to detachment, exudative detachment of retina. So a very severe complication. I want to show you OCTA of the right eye and left eye of our little patient. I want to show you the irregularity of foveal vascular zone on right eye and left eye too. And this can be due to prematurity or to the pathology, so we can discuss this theme. I want to underline that dermatologic lesions, skin lesions, occur in 100% of patients, and the ophthalmic findings in 36% of patients, and neurologic one in 30%. We can have convulsive disorder, spastic paralysis, motor and mental retardation, seizures, and cognitive motor delays, and learning disabilities. So for these children, it's very important to perform a magnetic resonance brain imaging because for exclude any pathologies. This is the ophthalmic classification of the disease. Stage 1 for eyes with retinal pigment epithelial changes only. Stage 2 for retinal vascular abnormalities. Stage 3 for epiretinal membranes, vascular zone, and neovascularization. Stage 4 for retinal detachment, and 5 for phthisis bulbi and secondary glaucoma, so extreme complication. Little girl was screened at birth for retinopathy of prematurity, and specialists told us that retina was good, so was okay at birth. Familial exudative vitreoretinopathy, Hill's retinopathy, sickle cell retinopathy, Coats disease, and the spectrum of Norrie disease. But skin findings are not associated with this condition, so are characteristics of incontinentia pigmenti. So we decided to perform argon laser of the peripheral ischemic area. This is the follow-up of the little girl at 4 months, and this is the follow-up, at 8 months. Literature advises schedule of monitoring. First of all, dilated eye examination after birth, then monthly examination for the first 4 months, then every 3 months for 1 year, and then twice per year for to up 3 years of age. The frequency of examination should be increased in children who have no eye manifestation, but there are no retinal manifestation and sign by 1 year of age. They are unlikely to develop later. To conclude, in IP is a potentially blinding disease, so it's very important to have an early diagnosis. It's important to test patients with fluorescent angiography and fundus photography. Because it's very important to determine the right approach treatment with laser and to follow up the patient. So it's very important to have a regular interval of follow-up and first of all, early detection, treatment, and good follow-up are the key to manage this very rare pathology, but that can complicate with retinal detachment and bad prognosis. Thank you all.
Thank you, Sophia. It's an interesting case. I think that the follow-up and all the information that you gave us led us to a discussion that should be, in this case, a very animated discussion, especially because we have Cristina that recently published a very nice paper on the AJO about the foveal avascular zone in prematurity, and is in all preterm babies, not just in ROP babies. And I think that, Cristina, this is a point in this case, because Sophia told us that possibly this could be a sign of incontinentia pigmented frustrated in the good eye, but I think that you can question this. You are muted. Okay.
Yeah, I agree. It's an interesting point, and basically, we are not able to prove what is the cause of the small foveal avascular zone. It can be prematurity, it can be IP, but I find this case very interesting because the ROP examination was was documented as unremarkable. So I would consider that vessels had grown or was screened and it was documented as complete, but clinically we were not able, or they were not able to see that there is some possibility of ischemia. So my question would be, if you have a baby born to a mother with IP and the child is born premature, would you do an angiography, say at postmenstruate PMA 31st week of gestation, or when does ischemia actually develop? So if you had known earlier of this case, you could have proven, ischemia starts at first month of corrected age. So it's a kind of it's a call or discussion about, hey, we should do angiography earlier, even kind of before birth in premature babies. And I assume we are way more alert to screen those babies earlier, and that would give us a chance to know more about the pathophysiology.
Of course, yes. This is a very challenging case because it comes to our observation, Sophia, at 6 years of age with an unremarkable history, with everything perfect, and even without history of ROP, except for being, born very early, 29 weeks, I think. So the question is that you can easily manage an OCT-A or OCT or Optos with fluorescent angiography at this age, but earlier on, I think that it's difficult, Christina, to manage a child like this with all the information. But of course, you're right. This is a challenging situation which you do not really know where is the truth, because it could be one or could be the others. Looking at the good eye, there is such a normal condition at the good eye that, except for the foveal avascular zone that you documented as a sign of prematurity, I would concur that the IP anamnesis, the appearance with this kind of fibrosis that's quite typical of incontinentia pigmenti is not something that is common in ROP. In ROP, I would see much more ischemia and leakage. So these are, my points, but you are absolutely correct in saying that, this is a border in which you cannot manage. Arif, what do you think about this case?
Yeah, thank you. It's very interesting. Most of the situations that we see with peripheral avascular retina, we think about like ROP and fever, they're really problems with VEGF is the issue. But this condition is a little bit different. The gene problem leads to a problem with apoptosis, and then secondarily they have problems with non-perfusion. It's not a problem with vascular genesis itself, so that comes secondarily. So in these conditions like ROP and fever, we're very quick to ablate or use anti-VEGF therapy. But here, it's a little bit less clear. Certainly, peripheral avascular retina is bad and will ultimately be a potential stimulus for VEGF. But the underlying etiology is not a VEGF etiology. So I think everyone agrees if you see significant disease in a very young child with IP, it should be addressed. But even if you're treating avascular retina, you're not treating the underlying genetic problem, so it's still going to go on until, as Sophia said, after about one, it's less likely to. So if you run into a child like the one you just saw, who has the fibrosis there and the peripheral avascular retina, it's not exactly 100% clear whether or not to treat that peripheral vascular retina. That's a bit debatable. I think probably the safest thing to do is to treat it. But, there are patients who come to adulthood and, they never have an issue, whereas there are others that go down. So it's a little less clear about with this VEGF, with the peripheral ablation in the older children, less clear than the VEGF-driven diseases.
I do agree with you, Arif. I do agree. And it's the same story with the Coats disease. It doesn't matter if in this situation, I think that the leakage was the problem. And leakage was the things that you were looking at as a dangerous situation. But actually, I agree with you that a laser treatment or anti-VEGF in this case is not an etiological treatment. Is a try. So I'm quite sure that you're right. Max, if you have questions from the audience, I think that this is the time that you can share questions.
Yes,
can I ask a question?
Not yet.
Yeah.
Yes, Kimberly.
Arif, I'm very interested to hear what you said then, because that screening, that's the paper that you referenced, Sophia, very nicely with the suggested screening criteria of no problems after one. It does worry me a lot if the message is you don't have to worry too much after one, maybe see them less and less. If this patient was 6 and they had been seen prior and screened for ROP, and now the problem's coming later. A few years ago, I had a patient with IP we treated at about 9. And we had also seen them regularly and were unable to pick up anything clinically between 2 and 5 or 6. So it would worry me. Love the panel to say, has anyone else had a patient like this, 6, 7, 8, 10 who they're treated, who for various reasons you weren't really picking anything up? Yeah. And so I'd be a bit concerned about the screening criteria saying that if you're safe by 1, you're fine. I think these kids need to be followed forever.
I don't think you're safe. It's just, I said it's less likely. They still need to be followed.
The screening, that paper suggested that you're unlikely to have a problem on their literature review. But I think maybe we all need to throw in our cases of ones we've treated after 5.
No, they definitely need to be followed for life. There's no question. It's just, it's less likely, most of the severe disease happens early on. That's all.
So, Christine?
I agree. We have cases, say around 8 or 9 treated, but I have to say those kids have not received angiography at earlier ages. So it was the ischemia was picked up later. And I personally, I'm not that aggressively following them, but I follow them. And since we have Optos available, also wide-angle angiography, so it's easier to pick up and perform angiography in very young kids.
Can I bring your attention to the fact that the OCT was showing a fibrosis? So I think that Arif, you're all right. You can just follow and see, because ischemia is not the issue, but the issue is the fibrosis. I understand that you can say that treating with laser, this part of the retina could even increase the fibrosis and create a traction and maybe worsening the condition. But still, I'm with Kim. The protocol usually in this condition suggests treatment because there is ischemia, there is leakage. So I don't know if this is really a case in which each solution could be better or good at the same time. So our point was treating because, even for the possibility of a quick evolution, because we said we saw this leakage and that was worrying us. But
can I just make a very quick side related point? There's a whole other discussion about patients with ROP who have peripheral non-perfusion. Some people feel very strongly that has to be treated with lasers. Others feel that you can just watch it. And that's a huge debate. And, it's...
Agree.
So things are not that clear.
So, Alki, would you comment on this?
Yeah, I mean, as a diagnostician, in terms of kind of the electrophysiology that we'd be doing, I think in terms of how you would treat or not to treat, the electrophysiology can show kind of functional changes within the retina. Not only just generally using a flash ERG, but also within the macula. So there's been a recent paper looking at children with IP showing that they have, through ERGs, they have inner retinal problems. And when they were old enough to do an OCT, it showed that there was a problem within the inner plexiform layer. So in terms of whether to treat, not to treat, I think the functional changes that we can see within either the pattern ERG and the flash VP can help the clinician make some decisions. I think there's many people around the world now using modified protocols that allows you to record these responses in infants and young children while they're awake with no sedation. But I also think that rather than just looking at the retina, Sophia brought up that 30% of these cases do have neurological problems. So as they get older and you're looking at their behavioral function, either their visual acuity, I think using VEPs also helps us determine whether the problem with the behavioral visual function is due to the pathology that you're seeing within the retina, or further back due to some kind of brain abnormality leading to a CVI. So I think if available, I think that the electrophysiology does help, and maybe that decision to treat or not treat if we see some functional changes before we see anything structural.
So, Aki, maybe a bit. I respect your position, but we are treating now, and we are seeing now a 6-year-old girl.
Mm-hmm.
So, I think that if you have any functional problem, will come very, very easily to see when an ophthalmologist sees her and sees that the visual acuity is worsening or something. I think it's much more powerful than VEP. VEP, is something that is useful in very young children to follow up there. But in this condition, if I have problems with the function at 6 years old, you can manage and you can see, easily with the visual acuity.
Yeah, I mean, in terms of I think if you have a decrease in visual acuity, though, and you have comorbidity of maybe a neurological problem and a maculopathy or some kind of macular changes, and when we know these children with IP do get macular changes, which is the one causing the reduction in the visual acuity? I think an assessment of the complete visual system, either just once or for monitoring, I do think is helpful.
Okay.
Thank you. I have a question, maybe to Arif. I'm not a retina expert, of course, so I'm just curious. Okay. I mean, what we know that VEGF increases, the vascular permeability, disrupting tight junction, and so that's why anti-VEGF agents, block VEGF activity, reducing the leakage, and so why maybe we use these anti-VEGF also in Coats disease or other, just for this reason, if we use that. Just wondering if in case like this could be useful, the anti-VEGF or is not useful at all.
I don't think it's useful at all because it's not the etiology of what's going on. It's true if the patient has peripheral avascular retina, that may lead to some VEGF drive later on. But the etiology for what's happening in front of us is not a VEGF-driven etiology. If I have, there's two comments I wanted to make, if it's possible, very quick, or do we have to move on? I just feel it's so important.
Go ahead.
When she showed that picture of the dragging in the right eye, one thing I just want to highlight to the audience is immediately you have to look in the periphery because that's just a sign that there's something in the periphery. It could be a tumor, it could be an infection. I mean, you don't know what it is. But whenever you see that dragging like that, you have to look at the periphery. And if you can't do it, you have to put the child under anesthesia. With wide field now, it's much easier. The other thing I wanted to say is that, it's very interesting when you see a case like this and you're suspecting IP, it's most of the cases actually are sporadic, they're new mutations, but a certain percentage of them are inherited. And it's always useful to ask the mother if there's any history of abortions. I think those are two important points that need to be highlighted from that case presentation that may have been alluded to, but I just wanted to make them clear.
Of course, miscarriage was one of the questions that Sophia missed to say, but we were, involved in asking the patients if there was a miscarriage. And Christina, just a second. Sophia, someone asked if the fluorescein angiography of the good eye was normal. Can you answer to this question?
Yeah, of course, was normal in early, intermediate, and late phases. Yeah.
Okay, Christina, you can go ahead with your question.
Okay. I just want to comment on the electrophysiology. This case makes it a bit tricky because the child was a preterm baby. So electrophysiology may be different from a child which was born on term. So it may be a mix of response abnormalities. Of course, if you do a longitudinal, then you may see the abnormality, so the changes. And the second one, the anti-VEGF, there are a few papers describing or documenting the anti-VEGF in IP. And it's a case report, just describes revascularization after VEGF treatment in IP, and then there's another case report about IP. They used anti-VEGF in IP, and the child became necrotized and enterocolitis. So I feel it's very vague, the anti-VEGF, and I agree with others. We should be careful about the application.
Can I just say one very quick thing that it's just so important, because the etiology is not VEGF driven. And as Christine just mentioned, there's remodeling. If you inject an anti-VEGF, you might be actually interfering with that compensatory remodeling, and you might actually make things worse. So we really don't know what we're messing with when we inject an anti-VEGF in there, because there is a normal function and there's compensatory mechanisms. So yeah, it's like stirring the pot and where you shouldn't be.
I concur with Arif. This case reports should be read, in a very skeptical way, because it's a case reports and it doesn't mean anything. But it's just try because we have anti-VEGF and we do something. I agree with Arif. This is a condition which you can even worse the situation. So
we have some question from audience.
Yeah.
May I read some? Maybe to Christina, this one. Hello. If we consider this case specifically, applying laser or anti-VEGF early would reduce dragging, but it would not affect the problem with foveal avascular zone. What do you think about this opinion, Christina?
I agree. The foveal avascular zone, the development of the foveal vasculature occurs early, and in this case, we don't really know, is it based on prematurity or on IP. But on the other hand, the other eye does not show the foveal hypoplasia, so it may be related to IP or the abnormal avascular. And I do not believe that the avascular zone would change after treatment.
Okay. Another question is,
sorry, Max, just to point out, foveal avascular zone doesn't mean that the child doesn't see. We have a lot of foveal avascular zone that are very silent from a functional point of view. So foveal avascular zone is a description. Actually, let me tell, even to Christina, Monte knows perfectly this, that the first one showing this without OCT was Ellen Mintz-Ittner. She published in 1999 a paper. No one cares about that paper, but she was the first one saying that there is a small foveal avascular zone in prematurity. She was really, brilliant at that time, as many things Ellen Mintz-Ittner did. In that period. Sorry, Max, to
Yes. Another question is, could it be a vascular tumor?
Not really that kind of OCT. The OCT clearly shows that there is a fibrosis. There is a big number of conditions which you have to look at the genetics. For example, Arif quoted fever. Fever is related to something that is now very, very trendy, that is the WNT signaling. WNT signaling genes means that there are genes that assign a polarity to the cells. Polarity means that when the vessels grows, they should follow a particular way. And when the WNT doesn't work, there is an anarchy in the vessels, and the endothelial cells goes everywhere. In that condition, you have mainly an endothelial problem, and the leakage is related to this. In IP, is not the same. So genes, in my opinion, will clarify many of these situations. Certainly, that kind of aspect is not a tumor-like aspect. This is my comment. Arif, you want to comment?
No, absolutely right. The WNT frizzled pathway, there are a bunch of genes in there, and when they're mutated, they affect the vascular genesis, angiogenesis of the retina, and it's directional, as you said. There, you do have a role for anti-VEGF potentially because, that's the problem. But again, as we've said several times, the mechanism in IP is different. So targeting that pathway isn't stopping the underlying pathology, but you might be able to manage problems that occur from non-perfusion. That's what you're doing, but you're not really altering the course of the condition when you're doing that.
Yeah, thank you, Arif, because one question was again, which anti-VEGF were used? So no anti-VEGF were used. So that's the answer. No anti-VEGF were used. Another question is it common to have unilateral disease in genetic disease? Maybe Cristina would answer, I don't know. Or Alcibiades.
It could be, and I feel the cases I know from our clinic in IP, it's usually asymmetric, I would call.
Alcibiades would add something.
No, very similar to what Christina just said. Is typically when you look at something that's unilateral, even when I'm presented with a case of unilateral nystagmus, if you investigate it enough, you usually see that it's bilateral with just very asymmetrical.
That's definitely true. It's usually asymmetric, but there are unilateral cases also, but they're uncommon, but they're there.
And be aware, it's X-linked. And X-linked is quite often asymmetric.
Okay.
I think there's a theme in the questions that they're just concerned that there was so asymmetric disease. One eye can be so fibrosis and the other eye can be completely normal. So there's been a few comments about, does that make the panel question the diagnosis? I think the answer is no.
There is another question, not specifically to address it to the IP, but on codes. Maybe we can ask this colleague say, have Coats disease that doesn't respond to any anti-VEGF. What would you do? Cryotherapy? Spots of laser not possible because of the edema. So what to do in those cases?
Can I say something about Coats disease? The problem with Coats disease is the telangiectasia and the change in the vessels. So if you close the vessels, someone demonstrated this. If you close the vessels, if you cryo the vessels, if you laser the vessels, you close the leakage, that is the exudation reason. This is what is Coats disease. It doesn't matter. You don't have in Coats disease any ischemia, or maybe later on you can have ischemia, but it's a secondary things. So my point is as tough as Arif was with the others, there is no reason to put anti-VEGF, to give anti-VEGF in Coats. There are case reports saying that they could work, and anti-VEGF, they work in many other conditions. But, the reason for Coats disease is that there is a leakage from irregular vessels that leak. That's it. So if you close that vessels, you resolve the problem.
Yeah, maybe sometimes it works because it stabilizes the blood-retinal barrier, That's why maybe some case report have some good results, but should be demonstrated very well that still. Wonderful. Any other comments from discussants about this case? We still have some minutes.
I want to congratulate with Sophia. She was brilliant and a perfect case. Congratulations, Sophia.
Maybe there is some question. Just a second. Let's see. Anyone?
Okay.
Yeah, we have a few times because we have still
just
5 minutes.
I noted down as the presentation was going on. It was an excellent presentation. I just wanted to mention, there was a little bit of foveal hypoplasia. Now that we have OCT, we see that so often, even in the normal population. So I really wouldn't make much of that in this case. I wouldn't know what to make of it. Another question that I had about this case is, and maybe I missed it, was the refractive error documented? I didn't see that. Do we know what the refractive error was?
No, there wasn't refracted error. 10 and 8 was the refraction.
Sorry?
But no refractive error in
Okay.
the girl.
Yeah, so she was 20/20 in both eyes, but maybe one was 20/25. So
Yeah.
So
And finally, you quoted a paper that said some different percentages of findings and 36% of ophthalmic. I think that the harder you look, I think if people looked hard, they would find a higher percentage. I don't know if that paper used wide field imaging, probably not. So it's a theme that was mentioned already when we were talking about the asymmetric disease. If you look harder, I think that percentage would be much higher for the eye findings in IP.
Totally agree. Totally agree.
We have another comment from the audience. He said, or she said, my experience is that even ROP sometimes develops completely asymmetrically. This is a very interesting and common situation. I mean, I think you agree. You agree with that.
Can I ask the panel? Sorry, you go ahead, Christine.
I just want to point out one thing, and we probably never be able to answer it. Does a retina of a premature child develops the IP-related retinopathy differently? So is the underlying retina more accessible or more vulnerable to IP retinopathy? We don't know, but I assume quite a number of children who have IP are born premature.
This, what you're mentioning brings up a very, very important point that I think is also worth mentioning about not only IP, but ROP in general and retinal vascular disease in general and many different diseases. We see some patients who have the same profile who have mild ROP or very severe ROP. And I think, something that is becoming more evident, we mentioned before the WNT frizzled signaling pathway. There are some patients who have mutations in those genes. And patients with mutations in those genes or mild mutations in those genes can get more severe ROP or even more severe IP, possibly. We always think about these genetic disease historically as, one gene, and we look at that one gene and that's the end. But it's becoming more and more evident that if you look at variations in these different genes that are involved in the vascular process, and there are more than probably 20 now, you'll find that the people who have more severe disease have variations in those genes. And these polygenic risk factors are, responsible for some of the variability we see in families, or again, in people who have ROP who have the same profile, but one person is much more severely affected than the other. It's variations in these WNT frizzled 4 pathway genes.
Wonderful. Kim?
Can I ask? I wanted to ask the panel something, and it might be my personal experience. The cases I've had, when the child is an infant with a skin lesion, there's heavy pediatric involvement, dermatology involvement, other teams. And later on, I've found that they all seem to, as the skin lesions get better and they're just seeing the eye clinic, it worries me. You mentioned Alki and Sophia, you mentioned the proportion of children with neurological disease. If this is a potentially progressive disease, has everyone's experience, do you tend to maintain heavy pediatrician contact too? Or have people had a varied experience with neurological disease in these children? Does that also progress significantly? Or does it tend to be done and dust in the first 2 years of life? What's the neurological disease experience? Arif, Christina, Alki?
Just a quick answer, please, because we have just 2 minutes. Just quick answer, please.
A mixed experience. Some are neurologically affected, some not. It's not progressive.
I would just say that, there's actually a role. We were talking about electrophysiology of the retina. I think there's a role for electrophysiology of the brain because that can reveal more. And I think it's actually more important because we can't see the brain, but measuring its function in that way can understand if there's a predisposition there.
I think it's a group that is studying PET in this condition. There is a group, I think maybe in Australia, Kim, I will tell you, there is a group studying positron emission tomography in these children with some evidence. If you look at PubMed, maybe you can find something. There are people working on it.
Last comment, Alcibiades, please.
Yeah, I mean, I agree with Arif that the electrophysiology of the brain is and can be useful, especially when a lot of these children with IP don't have really structural lesions within the visual pathways, but they have functional lesions because of either an epilepsy, and we can see whether that's affecting either one hemisphere or both. When you carry out the VEP, you can see epileptiform activity, whether it's time-locked, whether they're photosensitive. So yeah, I'm just agreeing with Arif that I do think there is a role looking at brain function using electrophysiology as opposed to just looking at the retina.
So thank you. Thank you, everyone, for this wonderful discussion. Thank you, Sophia. We are perfectly in time. And so if you don't mind, Kim, I will hand over to Susanna for a Strabismus case. So please, Susanna, it's up to you.
Thank you. It's a pleasure for me to share a case on strabismus that I hope you'll find interesting. I will share the screen. We present a case of a 67-year-old woman, plastic surgeon with Parkinson's disease, that the patient's main complaint was diplopia in near vision. She had normal brain and orbital MRI. She had hyperopia, larger in the right eye, with good visual acuity in both eyes. She wears full correction for her hyperopia with addition +3 for near, and she had normal fundus, as you can see in the retinography. She has exophoria for distance without diplopia and diplopia for near vision. Under cover test, the measurements are 11 Prince diopters for distance and 25 Prince diopters for near. She had full rotations, and the diplopia was just for near. So the diagnosis was concomitant exotropia, larger in near vision, with conversion insufficiency. The patient did not achieve satisfactory results despite previous treatment, including orthoptic exercises and basic prints for reading. So we consider the surgical alternative. Surgery in these cases is very challenging because we can obtain overcorrection for distance and in lateral gazes. So it's very difficult to decide the opportunity for the surgical treatment. Here you can see the different kind of procedures that can be used in these cases. We decided to perform the bilateral 5 mm medial rectus inferior fiber plication. A 6-aught vicryl suture was placed 5 mm posterior to the insertion of the medial rectus, including only the inferior fibers of the muscle in both eyes. The suture was passed through the sclera anterior to the insertion of the medial rectus, and then a third U-stitch was placed adjacent to the first stitch. The suture was tightened, ensuring that the fold remained beneath the muscle belly. Here you can see a video showing the technique. He is putting the stitch 5 mm in the inferior fibers only of the medial rectus with 6-0 vicryl suture. Then I performed the stitch in the sclera. It's very important to put this stitch in the sclera, not in the muscle. And then the second stitch near the first one. I am tightening the suture and the surgery is ended. Just the inferior fibers in both eyes. Here you can see the medial rectus at the final of the surgery. Like this. It's a very brief surgery. The first day, she presented with diplopia for distance and 12 Prince diopter isotropia for distance and orthophoria for near vision. 1 week later, she had 8 Prince diopter for distance and remaining orthotropic for near. At 1 month of the follow-up, the patient achieves orthophoria for both distance and near without diplopia. The patient continued to maintain orthophoria for both distant and near with no recurrence of symptoms. She had a stereopsis 200 arc-second by the lung test. In this publication by the International Parkinson and Movement Disorder Society, they report that conversion insufficiency type visual symptomatology was more prevalent in patients with Parkinson's disease compared to those without this condition. And in the algorithm that for the treatment of this condition, they don't consider the surgery as an option. In this another publication in 2018, in patients with a near-distant disparity larger than 10 Prince diopter, the author compared 3 kinds of procedure. The slanted bilateral lateral rectus recession, the improved unilateral medial rectus recession and lateral rectus recession, and the bilateral augmented lateral rectus recession based on near deviation. While the results were not statistically significant, they report that each procedure has a specific postoperative concern. The group 1 had vertical pattern strabismus, the group 2 undercorrection, and the group 3 overcorrection. Recent evidence demonstrated differential compartmental function of extraocular muscle fiber groups. So, selective surgery on muscle fiber groups may diminish near-distant disparity while maintaining alignment at distance. In our case, the procedure we chosen was very effective to obtain symptoms free of the patient, and I think it's important to report that in this kind of patient with Parkinson's disease is an alternative to improve the quality of life of these patients. Thank you.
Excellent. Excellent. Great presentation, Susanna, with a lot of information, because our attitude toward this treatment is very, very dissimilar all over the world.
Yes.
So, Monty, why don't you start you are the giant in this group of strabismus. So we wait for your comments.
No, very interesting case. I have no experience in the slanted procedures. To me, and to some extent, especially on the lateral rectus, the slanted procedures don't make a lot of sense since the DEMER has shown that the lateral rectus doesn't change with convergence and that kind of thing, the superior and inferior pole. You had an amazing result. I think that the lesson learned in convergence insufficiency, as in intermittent exotropia, is that it's a difficult to correct permanently type of problem. It's a problem that tends to recur. I think 6 months is an impressive result, but my guess is that partly too because of the Parkinson's that this is likely to return at some point. Nevertheless, you've helped this patient for X amount of time, so I think it's a valuable procedure. It was interesting to look at your data in your case, and by just plicating the inferior pole, you got the same correction at distance and near. Initially, the patient went from 11 PD of exophoria at distance pre-op and 10 of ET post-op. So it's about 23 diopters of correction and 25 diopters of correction at near. So that was pretty impressive that you were just doing one pole and got the same effect at both distance and near. And now the approach I like is the group 2 from that one study. I have always liked doing differential surgery, resecting the medial for the near deviation and the lateral for the distance deviation. I think the devil's in the details here in terms of how you augment the surgery, what table you use, and that kind of thing. But I think it's a difficult problem to treat, but I think you had an amazing result. I would also mention a little bit about non-medical treatment. This is a condition you never want to talk patients into surgery because it's just very, very devastating when you get a permanent overcorrection and they have constant diplopia. They will be very unhappy and they will say, "Doctor, I am much worse now than I was pre-op." So you have to be careful to not talk patients into this. The prism therapy I found useful for short-term treatment, temporizing in a tax accountant right before tax time. You can't have surgery. It's been useful to give them some basin prism for near till they finish tax time, and then you can do the surgery. The exercises also work well, but they're never done religiously for very long. So again, temporizing procedure, patients who don't want surgery right away, I think it's worthwhile for them to try. Good orthoptic exercises, convergence exercises, they do work, but it's really almost impossible for patients to continue this for the rest of their lives, which would be required. So I think there are many different treatments you can use here. This was a very interesting one. Again, I have no experience directly with it, but again, theoretically, it was an interesting case.
Kumur, would you add something?
I think I think it's very important to tell the patient that she can have diplopia in the first days of post-operative because important to say this thing, and I think that the correction for distance and near is because fusion. Fusion is the clue.
Yes, very, very true. And these patients have good fusion potential. They're normal. They have decreasing reserve because of the Parkinson's probably too. I don't know that there's a lot of really good studies on surgery in Parkinson's disease. That may be a different entity because they have the additional motor problems related to the Parkinson's disease.
Okay.
Thank you very much for this excellent presentation. I would like to mention about this particular case, instead of taking a whole lot of discussion about intermittent exotropia, which is larger at near. That might be another topic, but it might be extensive to discuss right now. So my first worry about a 67-year-old adult who is presenting with diplopia in the clinic for the past 2 years is bothersome. I mean, I think it's the number one rule of thumb is to rule out the other medical conditions which might interfere with this what looks like a straightforward procedure. So with this lady, it turns out to be more likely the Parkinson's state. It is documented that people can develop convergence insufficiency with Parkinson. However, there are some other rare causes like recent starting Graves' disease, which might not be clinically active, but one of the first starting symptom can be convergence insufficiency. And the other thing can be a remote possibility, but a myasthenia. Myasthenia is a mimicker of any motility problem. These two conditions have to be dealt with medical terms instead of running into a surgery. So for me, when someone steps into office with recent onset of diplopia, it's a team effort that has to be taken into account. Some Parkinson disease treatment, the levodopa, has been reported to relieve some of the convergence insufficiency symptoms. But with this lady, a plastic surgeon, I would like to eradicate some reasons of typical Maddox convergence insufficiency classification. The number one cause is she has significant anisometropia of about 3 diopters, so which can cause an anisoconia and weak fusional vergence mechanism. This weak fusional convergence mechanism can kick into place when significant presbyopia, which needs a 3 diopter of correction, is needed. Altogether, she has about 9 diopters of reading glass aids. So I have to check with the opticians whether there is any displacement of the addition, which might increase, let's say, a 0.5 centimeter or a centimeter of displacement may cause easily a 9 prism diopters of exo effect at near. So these are the things that probably has to be checked for. I'm sure Susanna has already looked for those things before running into a surgery. And the third thing is about anisometropia. In my clinic, I find a retinoscopic examination is essential in order to give the best viable refraction as possible for these fusional vergence mechanisms, to enhance the fusional vergence mechanisms. Some people are off about 1/4 or even 3/4 of diopter it might be important in 3 diopters of anisometropia cases, because we know for fusional vergences to take in, the vision has to be perfectly clear at the macula. So the number one reason is the accommodation convergence reflex is not there because of presbyopia period. She might have insult with the tonic vergences because of the Parkinson's disease, and her fusional vergence mechanism can be interrupted by the anisometropia and the little amount of stereopsis. The stereopsis is not perfect, so I'm concerned about it. So I don't want to extend the discussion more into the etiology, but once we are sure that there is a convergence insufficiency which is not cleared by PRISM's application, then we can run into the surgery. Of course, she's a plastic surgeon. Her double vision has to be dealt with. My point of take from among the lists of surgeries of Susanna is presented is basically, I'm not very impressed with any one of them other than creating a little bit of V pattern. I think Monte has made a good point that even inferior application caused a distance correction of about the same size. I think compartments is very well documented both scientifically and clinically, but creating a little bit of V pattern might be helpful for the maintenance of convergence.
Thank you, Kumar. I would have some opinion about Dr. Venkat Rao. Could you join us?
Yeah, hi. Can you hear me?
Yes.
Yeah, it's an excellent presentation. And same as what Dr. Monti said, I really don't have much of an experience with the plication, especially the selective plication of the inferior half of the medial rectus. No, and again, I agree with Kumar. The surgery is the last resort for these kind of patients. Generally, we don't jump into surgery as a first resort. Of course, and she's a plastic surgeon, and she probably had for 2 years, and she went through everything possibly, and then they had to do a surgery on her. We have had, this case, I think probably would classify into a pure convergent insufficiency kind of a problem where she had exotropia just for near and probably none for distance, or maybe she had exophonia. In this kind of scenario, I would probably, generally, we have done few patients with not Parkinson's though, but not normal pure convergent insufficiencies where we did a medial rectus kind of a resection rather than plication, explaining to the patients that they will be diplopic for distance because you were creating an esotropia for distance, and they will be very unhappy if you don't tell them prior that they will develop an esotropia. Most of the time they trade off for that because they are suffering with this convergent insufficiency exotropia where they are unable to work for near or read for near, and they have double vision. So the trade-off, would be that if they develop esotropia, you may have to put them into prism glasses temporarily until the esotropia generally goes away after about maybe a couple of months to 2 to 3 months down the road. The ET goes away, and for near, over a period of time, again, some amount of convergent insufficiency starts kicking in. Of course, initially, it might look good, but over a period of time, as Dr. Monti said, it tends to recur back, but not to the same extent as what the patient would have had prior. The other thing I was wondering in this patient was, why would we call this as an incomitant exotropia? This is incomitance. Is it for near and distance? Well, I don't think so. There was a lot lateral incomitance here. And other thing was her deviation in the down gaze was less as was in the primary gaze. I was not sure, Susanna. Huh? Was it the same?
The same
It's
in
the same.
up,
It's it.
down gazes.
And what about in the side gazes?
Yes, the same.
The
10
same. Good.
imprints diopter. Yes, it's very comitant in lateral versions and in up and down gazes.
Yeah. So when we do a selective plication like this, do you expect any limitation in abduction? Did you get any limitation in abduction? I mean, sense an incomitant esotropia into the side gaze when she looks into the, and because we did bilateral, so bilateral side gaze, did she have a double vision post-op?
Yes, in the first day she had diplopia, yes. But
In the side gazes, yeah.
yes, in the side gazes and for distance.
Correct, yeah. Yeah, so yeah, this is expected, so after the
Yeah.
resection, you will get this. But my experience, I haven't done any of the selective plication thing. So, but overall, I think it's a good result. She's happy with the result, considering that she's been kind of diplopia free post-op. Yeah.
There is some
Another
question.
alternative could be the central plication of the medial rectus, but I have no experience with this. I think that cases like this are very unusual.
Correct.
So it's very difficult to join big data. I couldn't find the publication related to create a V pattern. I have. Do you know if somebody have published the results of the V pattern as a treatment of this condition?
May I?
Yeah.
To create the V pattern.
Yeah, well, let me get back to your question a little bit before these explanations. Lately, at one of our meetings, Rosario from Spain has presented a case like this, an elderly patient who she applied a unilateral medial rectus central plication, which turned out to be the same scenario in just 6 months. So it didn't stay there. So the second step, she used bilateral lateral rectus inferior recessions. You can name it slanted recessions. It was there for 2 years, and then the symptoms came back. And then as a third procedure on the same patient, she had to go back and do medial rectus inferior resections. And by 1 year, the patient is already fine. So basically, that is only one patient, but I believe there is a lot of case reports out there which can claim that one surgery has been superior to the others, although there are not really controls. In my clinic, there is not many patients where I can employ a controlled study to prove that one technique is superior to the other. But my point from my take-home message from these separate case presentations is instead of focusing on what can be achieved in a central mechanism of insufficiency, is trying to apply a easily adapted vectoral forces. I mean, instead of trying to pull the medial rectus inside, you can apply a small bit of V pattern there. The slants or biased pole surgeries can create that instead of creating a better medial rectus tonus in there. And one has to look at least about several years, or at least say 5 years, to see the result, whether it is permanent or has been just there for several months. Obviously, for a plastic surgeon, several months outcome is not satisfactory.
Okay, thank you, Kimur. But we have a lot of questions, Max.
Yes.
Just brief answer to the question. Otherwise, the discussion is not very fast, and this is an interesting case. Max?
We have some questions from the audience, and for Susanna. Susanna, do you use absorbable or non-absorbable suture first?
Yes, absorbable sutures, Vicryl, 6-0 Vicryl.
Yes.
Okay. Another quick query is, can patient get Webino, wall-eyed bilateral internuclear ophthalmoplegia in Parkinson disease? Could be?
I don't know if it could be. Yes, it could be, but the patient was very free of symptoms, neurological symptoms with the medication. So
But Webino is never with 11 diopters. It's a 40.
No.
No.
Another interesting question is, perhaps the result in the cases presented would have been the same with the standard plication rather than an inferior-only plication.
Yeah.
I have some issues with that. I discussed about slanted procedure with Bartol Cushion for a long time, and what we have seen that if you consider as B-pattern isotropia, and you recess the superior pole more than inferior pole, like a Simon's procedure, you have good results because it simulates the infraplacement of medial rectus. Fine. Well, but the important thing is that in the literature, you have the same results with the opposite procedure.
Yeah.
With, the inferior pole recessed more than superior pole. You have the same procedure. I translated for Barton, an Italian paper for a long time ago, and and you have same results with different procedures. That's why, maybe just because the effort is related to recession or resection, whatever you do, and not the slanted procedure. So we don't know how they work. Monty?
Yes, I think that makes a lot of sense. I would second another comment that Kumar made. I think this case is unique in a number of ways. In addition to the Parkinson's, is the anisometropia. This patient's had anisometropia their whole life. So that right eye, I think, is amblyopic. And not terribly amblyopic, different, but the best corrected vision was 0.1 different. And so I think she has a strong left eye preference. And I think she's going to have reduced fusion. It's demonstrated by the reduced, as Kumar mentioned, the reduced stereopsis after a good result. That's going to complicate your surgery further down the road. Fusion is not going to be as strong. And again, to me, another reason why I would prefer to do resect, a biased resect on the non-dominant eye. I find patients bounce back from that much faster. They're much more comfortable post-op because their good eye is not being touched. And so, again, that's another reason. I think the case is unique.
Let me get in. So let me use my privilege of being a moderator in this condition because I want to point out something. You have seen that all over the world, from India, US, and Turkey, the position is just, to be a chicken surgeon in this situation. So there is no reason to push towards surgery. So I do prefer, in any case like this, what is a forgiving procedure. So I like very much the procedure that Susanna proposed, because his application is not a resection of the muscle. So my idea is that you can try with this one, but in 15 days, you see still the angle is in isotropic. You can take out the suture. So this is a one condition in which I am a fan of application over resection at this time since I think 8 years now. So application works and works with absorbable. We don't know why it takes this so strong, the absorbable, but I use absorbable and I think it's a safe procedure. So with respect to compartmental surgical procedure, this is the only one that I accept that is application of the inferior pole of the medial rectus. I agree with Monty that working on the lateral rectus doesn't have any effect at least, unless you don't do a recession of both lateral rectus for the near angle. In that case, this is also another forgiving procedure because, you can manage smaller angle with recession of the lateral rectus, and it's a forgiving procedure, but still, I think that this is a condition which you must be very careful in doing everything. Another point for Kumur, I have experience with insufficiency of convergence in people with traumatic whiplash. This was, I have a series of about 10 patients that had whiplash, and that was one of the causes of insufficiency of convergence.
Well, another comment from the audience was, we discussed about that also last time with Monty, and the other one was the Ed Buckley procedure. He suggested in one paper to recess the lateral rectus for the distance angle and then create a V pattern by a bilateral medial rectus elevation. I have done some procedure actually. And I would like to know if this, the panelists have some experience with this technique.
No, I have no experience, but it doesn't make sense to me that the V pattern is going to be helpful. I mean, that assumes that you do all your reading in down gaze, and most patients do a lot of reading in primary gaze. So yeah, these procedures where you try to create a V pattern doesn't make sense to me to be a solution that would be useful. You're creating an incompetence. And the other thing with these slanted things, which was presented in one of the papers that Susanna presented, is that you often will create some vertical deviation problems as well, and as they did in that study too. That's another reason I think it's a little bit suspect. And finally, the doses that are used for these slanted things are sometimes very small. I mean, there was a paper where they did 1 millimeter more or 1.5 or 2 millimeters more. I mean, that's homeopathic treatment differences. So I don't know. But I do like the difference between distance and near using the medial and lateral in that regard.
Okay. May I ask the panel, how many of you are using prism adaptation for this kind of, or any kind of exotropia cases, symptomatic, with the fusion potential?
I use it in the office. I think I do office fusion testing.
Yeah. Office prism adaptation. That's right. I'm at home. Right. So basically, what I don't know if Susanna has applied as on office prism adaptation for this case or not.
No, not in this case.
Yeah, well, I really find it interesting to maybe not in this case, but especially for patients both in esotropia and exotropia, what may turn out to be a basic deviation, not a distance near disparity. The distance near disparity can vanish with prism adaptation, what I'm saying is. And the nice thing about that is then I can know to what extent I can increase my surgical numbers. People are complaining about temporary results, which turns out to be unsuccessful in terms of alleviating the patient's symptoms. I think that is useful. And the other question is, like Susanna's case, it turns out to be a 25 prism diopters of correction at distance. So adjustable sutures, aiming at adjusting these patients to what? Say 5 prism over correction, 20 prism over correction, or 35 prism diopters of prism correction. Until when do you want to do the adjustment, or let's say a redo surgery? That might be another question.
Come on.
But I'm not going to tell it now. I'm just asking the idea of the panel here.
Come on, I think you need another hour. I'm sorry, we don't have it. We're going to have to start wrapping up a bit. But I did want to ask you one. You can answer in 5 words, please. Paolo, Monty, Venkat, and Susanna have given us their go-to operation You've talked about pros and cons of all of them. What is your first operation, excluding all your problems? What's your first preference operation for convergence insufficiency of this type?
Monty.
Yes.
No, to you. Everyone else, Monty has given his.
I think I've already hit on mine. My preference is to do the non-dominant eye, to do the use the lateral rectus resection for distance and the medial rectus resection for plication. I think it's a good choice as well for near, and I think that works out very well. You don't get
your first choice is all I want. Venkat, I think you said you prefer medial rectus resection. Is that correct?
My first resection. Yeah, my first choice would be medial rectus resection. Yeah. But I would do bilateral.
Yeah, well, I would definitely would like to learn about the prism adaptation outcome. Then I will know what to do. But
sorry to be rude. Yeah, the 5 words. We have to finish up very shortly.
I always use plications instead of resections, let me say.
Okay, thank you.
It's very controversial.
Yeah.
Surgeon has its proper.
So this is common in strabismus surgery. It works everything. So you can do whatever you want.
Or nothing.
Or nothing.
Yeah.
So I don't know if we have 4 minutes, Kimberly. We should actually. I would have continued with this powerful discussion. So great panel, great observation, great feeling of being all over the world with a different position, but each one sharing experience, because all of us have a great experience. So it's really a powerful thing that the WSPOS endorsed since the beginning. So I think that Kim, we have to say thank you to everybody. The meeting was Kimberly. Yes, there is audience questions. So maybe you have to pause, Kim.
Oh, sorry. Sorry about that.
So it is something that we have to share. So the certificate, Max already told you to ask the certificates. So it's always a pleasure to be with a panel like you. Let me thank once again one of the youngest residents that was so proud and so brave to present in this session with all these names in the world. So thank to everybody. It was really an exciting afternoon. Can we close, Kim?
I've got a couple of announcements to make. Give me 2 minutes. Sorry. Look, yeah, as you said, let me just get going. Sorry. I'm sorry to interrupt everybody, but we have to finish up shortly. Can you see the screen there, Paolo?
Yes.
There's plenty of other questions, and what we might do is collate the questions and send them to some of the panelists for answers too, and we'll respond to the questioners. There's a few more webinars coming up. There's a whole series of webinars with Yossi, which is the Young Ophthalmologist Society of India. The next one's on amblyopia. So stay posted on WSPOS website. Anyone who's online and watching, please, if you're not a member already, most importantly, it's free. It's free. You get benefits for that free membership. You get these educational webinars and future events, but there's also some access to journals as well. Please go to the website and look if you aren't a member already and spread to your faculties. David Grunnett wanted to pass on, please. Anyone interested, you can email him at dgrunnett@ucsd.edu. You can see that, screenshot it, your name and where you're training. If you'd like to join his listserv for a very interesting case discussion. So lastly, I just thank the audience around the world for watching and paying attention, and particularly my fantastic colleagues here. The moderators are always animated and helpful, and sometimes double as great panelist discussants. As Paolo said, we're very, very appreciative of anyone who brings cases like this, the time you put into the presentation, the excellent effort you go into literature searches, and all the photos and quality materials that you present. We really appreciate it. Thanks so much. And of course, the time given by our discussants and our experts, the premiers around the world in the non-strabismus and strabismus areas. Thank you so much. Really appreciate your time. I'd like finally to thank NTOD for support and hosting this webinar, and thank you, of course, to our administrative staff from WSPOS, which this wouldn't happen without them.
Thank you.
Thank you, everybody.
Thank you, everyone. Yeah.
Thanks.
Thank you. Yeah.
Great
Good night,
meeting.
good morning, and good day.
Good
Good day.
Bye.
Thank you.
Thank you all.
Bye-bye.
Yeah, thank you.
Ciao a tutti.
Thank you. Bye.
Bye.
Congratulations on the residents. Yeah, that's
Great
right.
presentation, Sophie. Sophia.
Congratulations,
Yeah,
Sophia.
really.
Thank you so much.
We so much
Excellent,
want to keep
excellent.
the young people involved in pediatric ophthalmology in the U.S. And it's great to see residents involved and medical students too. So congratulations. Great presentation.
Thank you so much.
Yep.
Thank you. Bye. Have a good day.
Yeah, you too.
Bye-bye.
Bye bye.
Bye bye. Bye bye.
Bye.
Bye, bye, bye.
Bye bye.